and welcome. You are listening to Transplant Talk. On today's episode, we have Dr. Whitney Jackson joining us with Brandy Carton, who's a double living donor. Dr. Davis is going to be interviewing them both and share more about their living donation journey. Over to you, Rachel.
Thanks, Kush. So this morning, like Kush said, we're interviewing Brandy, and Brandy is our second double donor that we're interviewing. She donated her kidney in March of 2017 and then the left lobe of her liver in May of 2019. And I'm actually very excited to talk with Brandy today because it was coming across Brandy's story on the UC Health website that led me down the path to actually applying and moving forward with donating. So super excited to talk with you, Brandy. And then we have Dr. Whitney Jackson, who's an associate professor of medicine and a transplant hepatologist. She's the medical director for living donor liver transplantation. So pleasure to have both of you today. Let's start by having you tell us a little bit about yourself, Dr. Jackson. Can you tell us a little bit about your role and how you're linked to living donation?
Sure. Like you said, my background is that I'm a transplant hepatologist. So I take care of people with liver disease primarily who are very sick and try to get them to transplant. It's really through that experience that I've learned just how sick our patients need to be in order to be quote unquote competitive for an organ within our system nationally. And that's really led me to just really advocate for living donor liver transplant, where potentially we can transplant people before they get extremely sick and have a better chance of recovery. So I'm very honored to work with Dr. Elizabeth Pomfret and our entire team here to just organize and lead the medical evaluation process for the Living Donor Liver Transplant Center here at the University of Colorado.
Well, thank you. And I want to come back later to something you said and have you explain more about why living donor means someone can get transplanted sooner. But before we do that, Brandy, do you want to introduce yourself and tell us your link to living donation, a little bit about your story?
Sure. So I am Brandy. I am a double donor. I donated my kidney in March of 2017 and the left lobe of my liver in May of 2019. It was back in about 2014, I was invited to the Facebook page of a local woman who needed a kidney. I didn't know her, but something about her story resonated with me. I'd also, when I was in middle school and high school, I babysat a little girl who had cystic fibrosis. And when she was 19, she was in Children's Hospital awaiting a lung transplant. And unfortunately, a donor never came, so she passed away. So at that time, I had told myself, anytime somebody needed something, a donation or anything that might come along in the future, that I would be willing to help, because I just couldn't stand the fact or the thought of another child or anyone waiting in the hospital for that transplant and then for it to never come. So I kept thinking about this woman and I thought, what if no one tests? So I called UC Health the next day and got on the list to come in and get tested. And unfortunately, we were not a direct match, but we entered the paired kidney exchange where we sat for about 2.5 years. She'd be ready for transplant and then her health would decline. And unfortunately, in December of 2016, she passed away. We were never able to meet, but we communicated on Facebook. I kept thinking she was a stranger. I was going to donate to a stranger. It was time for my testing to come. I needed to retest to stay in the database. And I just decided to go back into the database on my own. And I matched almost immediately with a man in Ohio. My kidney went to Ohio again in March of 2017. And then 2 years later, at my final kidney checkup with UC Health, I expressed interest to become a liver donor. Long story short, I matched with a baby, and he is now 5 years old. Both recipients are thriving and doing well.
Wow. So I have a lot of questions after that. But one of the things that stands out to me is that, I think, well, you had a couple of losses, right? It sounds like people who were one who you knew and was important to you and one who became important to you. And I'm always interested in how people respond differently to loss. And it sounds like what you did is you moved forward and tried to help people and make meaning out of that. Do you have a sense why that's how you coped with loss?
I don't know. I've always been a giver. I'm not rich, so I can't give financially, but I've always volunteered my time. I've always been just a giver. And I felt like with Jessie's death, the little girl with cystic fibrosis, I felt like the only thing that I could do is possibly give in the future because I could not let another child just pass away like that. I just felt like it's hard to explain, but I felt like this was what I was supposed to do.
And I don't think most people would probably respond that way. Do you? Or
I don't, and it's a valid reaction to something like that. Not everyone is willing to donate an organ to somebody they know, let alone someone they don't know. So it's definitely not a reaction that everyone would have, and I really can't explain why I felt the need to do it not once but twice.
and I'm guessing since you did it twice, your experience must have been a positive one?
Both times it was extremely positive. I can't My kidney donation experience, the whole process was amazing, from the testing, from the surgery, the team at UC Health. Had I not had such an amazing team, I honestly don't think I would have pursued liver donation, but I trusted my team completely. I can't say enough good things. And because of my experience at UC Health, that's part of the reason that I decided to donate again.
And what else was positive about the experience?
I've been able to meet both of my recipients. Again, they were both strangers when I donated, but I have an amazing relationship with both of my recipients. Rob, who received my kidney, is like a brother to me now, and they're amazing. And I am so blessed. I think I tell them sometimes that I'm even more blessed than they are to just have the opportunity to watch them thrive. I knew going into this, there was a possibility that I would not get to know who my recipients were. But the fact that I'm able to watch both of them just absolutely thrive in their lives is amazing and such a blessing.
And what did they think of you?
So I think sometimes it's hard, especially for his family, since he was a baby. It makes me very uncomfortable to be called a hero or to be told that I'm amazing, but I do hear that from their families. They're very thankful. And I just remind them all the time that I'm even more blessed sometimes I feel than they are because I get to have them in my lives. And they really are just like family. They've done so much for me and my girls that it's just been an amazing experience.
Well, and I can relate to that. I think, you're in healthcare also. And I think being in healthcare, we get to help people, but not this directly. And there's something just incredibly profound about having the privilege of helping someone that directly.
You're able to see it, what organ donation does for someone and for their families. That makes it even more impactful. A lot of people don't get to see that, what changes happen in a person that receives an organ, or even their family and friends, what this person gets to continue living their life and experiencing things with their family, friends. And I think it's an amazing part of organ donation when you're able to see the result of your donation.
Right. Well, I want to come back and hear more of your story, but back to you, Dr. Jackson. You mentioned that living donation allows people to receive transplant sooner. Why is that?
Yes. Well, let me just start with, what the challenge is for our patients who are waiting for a liver transplantation. The challenge is that there are many more people that are waiting for a transplant than there are organ transplants available in our country. And so there's always a gap between the supply and the demand. Most recently, our statistic is that 13% of the wait list dies each year waiting for a liver transplant. So in order to prioritize who gets organs first, our country has come up with a system where the sickest person waiting is the person who gets the organ offer. We decide who's quote unquote sickest based on something called the MELD score, which is a scoring system between normal is 6, 40 is the highest, where somebody's the sickest. And so organs go to people with the highest MELD scores first. And so you can imagine, liver disease is not like end stage kidney disease where you can go on dialysis while you're waiting for an organ offer. We are really trying to keep people alive and keep people going while they're very sick from end stage liver disease. And so what happens to people while they're waiting is they can get sicker or more frail, and they can lose their opportunity to safely undergo a liver transplantation. The national average for MELD score for liver transplantation is around a 30. Whereas our center recently did a study to look at what MELD patients benefit from a liver transplant and a living donor liver transplant, and it was closer to a MELD of 11 to 12. So you can just imagine if you have a living donor available to donate to you, you can get transplanted much earlier before you're sitting on the wait list, waiting with time accruing, waiting with the risk of getting more sick or more frail and losing your opportunity and dropping off of that wait list. And so not only are you getting transplanted earlier when you're healthier, better able to recover, but you're escaping that risk of time on the wait list.
So when you have someone who's a non-directed donor like Brandy or like myself, how do you decide where that liver goes, given that you're not doing it based on MELD scores?
That is an amazing question. And it's actually something that is, part of a national conversation that there is no national system for allocating non-directed liver donors. So when a non-directed donor comes to the University of Colorado, they are entrusting us to allocate that liver to who we think is most in need. And there are a couple of ways that our center, and this is also very consistent with that national conversation that's going on, but there's a couple of ways that our center, a couple of factors that we use to allocate that organ. So first of all, blood type is the most important thing. Somebody has to be blood type compatible to receive that organ. That's, A, B, or O, the positive or negative does not matter. Then it's based on size also. So the size of the liver graft that's available has to go to a recipient where that size is going to be enough to help them and to regenerate in them. So, for example, you can't give a very small piece of a liver to a very large person. That just might not be enough for them size-wise to do well. So those are really significant factors. And then we do still prioritize based on urgency. So what is generally considered to be the MELD score. And what we do is we work very closely with Children's Hospital. We know that children who are 1 year old or younger are the most disadvantaged on the wait list. So our center, and especially this is really like a value that has been led by Dr. Pomfret, our center has decided that we will look at the children's list first always. Because if you look at everybody and who is the most disadvantaged, it's those 1 year olds and younger. And it's because of the size discrepancy. If a deceased donor organ becomes available, there's a very high likelihood it will be too large for somebody who's a baby. It's just too big for their body. That's actually why living donation is such an amazing gift to these kiddos. So what we'll do is we'll look first at the children's list. We'll look at sizes and severity of illness to see who would kind of be allocated to first. And then if there's nobody that's blood type or anatomically compatible on that list, we'll then go to the adult list. It's also really important to emphasize that there are a lot of adults that are also greatly disadvantaged on the wait list. And most significantly, that would be petite females. They just tend to not have their MELD score bumped quite as high as males and as larger people.
So one question, can you help me understand? So you can take part of a liver from a living donor. Why can't you take part of a liver from a deceased donor and give that to a baby or a petite woman?
You can. So there is such thing as dividing a deceased donor liver. It's a technical variant. Graft is what we call it. The surgeons take that deceased donor liver, they get a CAT scan, imaging, and they find a place to split it as well. That just seems to not happen quite as often or to be as readily available. But our center is one of the centers that has an expertise in that also. Usually what happens is they'll split and take the left lateral segment of that, give it to a baby, and then hopefully the rest would be large enough to go to like a petite person on the adult wait list also. So it does happen. It just doesn't seem to be enough to be rescuing these kids and petite females from death on the wait list.
So do most centers not do that?
That is something that requires great surgical expertise to split a liver, both a deceased donor to make a technical variant or a living donor. And no, not all centers do that.
Okay. So for living donors, how much liver can you safely take, and what part of the liver do you take for different types of recipients?
Sure. There are basically three types of donation. So a liver donor has to be left with 30% of their total liver volume for that remnant liver to regenerate completely to be everything that you need. The three types of donation are a left lateral segment. That's the smallest portion of the liver. It's about 20% of the total liver volume. It's usually enough for a child or a baby. The left lobe, which is about 30 to 40% of the total liver volume. It can be enough for a very petite person or an older child. And the right lobe is generally needed for an adult to adult living donor liver transplant. It makes up 60 to 70% of the total liver volume. And the risk of that resection is proportional to the amount of volume taken, and the size needed for the recipient is also proportioned to their size and how sick they are. And so really size is always a balance where we're trying to minimize the risk to the donor, but maximize the benefit to the recipient.
So, Brandy, do you know what percentage or portion of your liver you donated?
I do. It was the left lobe, 18% of my
Okay.
liver.
Tell me a little bit about your recovery process. I guess we'll start with you, Brandy, and then Dr. Jackson. I want to hear kind of what you see with other donors. But Brandy, what was recovery like?
Well, I'm not going to lie. It was rough. Going into liver donation, I was told by my team to not expect the same recovery as kidney donation. So I was totally prepared. There were some really dark days. Getting pain under control was a challenge. I had a low heart rate for a little bit. And it was really uncomfortable. It was the days in the hospital were, like I said, they were pretty dark days. And I just kept thinking about my recipient. So that got me through. Once I got home and had the drain removed, the central line, things started to improve a little quicker. But since I did have such a large incision, getting back to normal took a little bit. There was quite a bit of fatigue that I was not. It was surprising. And it usually hit at the same time every day. So that lasted a little while, but it was exactly 3 months to the day that I felt normal. And that's what I was told. It would be about 3 months. So liver was definitely a challenge, but well worth it. There was pain with a purpose.
Yeah. How large was or is your scar?
It is right at my breastbone and goes down a little bit past my belly button.
Okay. And how do you feel about your scar at this point?
I love it. I actually got my belly button pierced to enhance it a little bit. There is a portion of my scar that opened a little bit, so it's not a beautiful scar, but I absolutely love it. I have no plan to cover it up, and I will show it off to anybody.
I totally get that. I like my stomach now too. I wasn't a big fan before, but now that it has the scar, I don't mind showing it. So, Dr. Jackson, is that pretty typical for what you hear from other donors in terms of recovery?
Yes, a couple things that stood out to me there. So, first of all, Brandy mentioned recovering from a living kidney donation is different than recovering from a living liver donation. Why is it different? It is a major abdominal surgery. A surgeon has had to technically separate the liver. And so it's just going to be a harder recovery. Most of our donors are in the hospital between 4 and 7 days. Most people are out of work between 6 to 8 weeks, sometimes more like 10 to 12 if they have a very physical job. People say exactly what she said. Once I started to feel better, I suddenly noticed how extremely fatigued and tired I was. That is because the liver is regenerating and is taking all of your energy to try to rebuild those new liver cells. And so just suddenly you're going to be taking naps during the middle of the day. And the other thing is just that 3 month mark. So, regardless of the amount of liver resected, I really find that at 3 months, most of the liver regeneration has occurred and people start to feel like themselves again. It's also perhaps important to note just that there's not a lot of financial support always for donation. And that, talking about that time off of work is really important for a lot of people. Some employers do provide salary support. There is something called NALDAC that provides some salary support for lost compensation if you qualify for it. But, travel and costs for staying locally are not reimbursed. And that's something that is still really a sacrifice that our donors are taking on, that financial sacrifice. And then 94% of our donors express that they would want to donate again if given the opportunity. So most people really do come out of this with a positive experience. Brandy's experience of meeting her recipient isn't always true. And I really emphasize that to people. You know, we require that donors and recipients remain anonymous if you're a non-directed donor initially. And then after a period of time, once each person has had the ability to recover, we encourage them to communicate if they would like to. However, you could imagine that on the recipient side, they might be going through something where it might be hard to communicate, or, I just can't promise that to people. So it's something that I really do bring up, that not everybody has that opportunity. Those are just some things to think about, I think.
So given what you've both described, I'll start with you, Dr. Jackson. Why do you think people do this, volunteer to do this?
Loaded question. Brandy touched on that idea that people respond differently in life to hardship, right? And there's a lot of good in this world and a lot of people that want to help other people. And I think that is really remarkable and inspiring, especially when you open up the news every day and you see so much negativity all the time. My experience working with donors, all donors, has been just so incredibly inspiring and positive. We do know that the people that step forward to donate seem to have certain personality types where tend to see their health in a positive light and have a lot of confidence in their own physical health. And that might be one reason that donation speaks to them a bit more than other people. Also, our experience in Colorado is just, we live in an amazing state. People are so giving here, and they also tend to be people who like to do things. And so maybe those are all things that play into it. I'm not totally sure. I think everyone's journey into this is a little bit different. And actually, if anything, I love just getting to hear from each donor what did bring them into this.
Well, and Brandy, does any of that resonate with you?
It does. I feel I've met a lot of donors in my journey, and I think there are the donors that donate to a family member because of course you would. I have met people that have also said that they would not donate to a family member. So I think that, again, organ donation isn't for everyone. Those that have donated to non-directed recipients, I can't explain myself doing it. I don't ever feel like I can give an adequate answer that anyone is going to understand. It was just something I felt like I was supposed to do. I'm not going to take any of this with me when I die. It's almost like it's borrowed. And why, if I can share it, why wouldn't I? Now, not everyone is going to have that same opinion. They're not going to view it the same way I do. But I just feel like some people give. Some people give financially. Some people give their time. And others just feel like this is something they needed to give. To me, it doesn't seem like it was that big of a deal. When, people say, oh, I can't believe you did that. To me, I don't honestly feel like it was that big of a deal for me to donate an organ to someone I didn't know. I would do it all over again. And it just wouldn't be a big deal. And I know people aren't going to understand that when I say that. It just wasn't a big deal. Well, how could it not be a big deal? It just wasn't. So I think every donor is different, but I think those that maybe there is something different about the donors that donate non-directed, that just makes you feel like that's something you need to do.
When I can relate to that, I spent a lot of time trying to figure out how to put into words why I was doing this, and even had a fair amount of maybe even negative self-judgment. Like, is there something wrong with me? Like, why do I want to do this? Why is this such a strong drive? And I think one of the things, Dr. Jackson, that you touched on, well, a couple of the things, but one of the things is doing something about the suffering you see in this world. And I think I'm a person who's very sensitive to other people's pain and suffering, and it feels much better when I can do something about it to alleviate that suffering. And I think this donating part of my liver was just an example of that. It's like knowing this world, there's a lot of pain in this world, but there's also a lot of good in this world. And I want to be on the side of the good. and this is something I can do. The other thing you said that I think is really interesting is the part about having a positive sense of one's own health. And for me, that's particularly interesting because I've grown up with obsessive compulsive disorder, and I've been not supposed to use this word anymore, but I've been a hypochondriac since I was a kid and grew up basically terrified of my body. But over the course of years, I've had treatment and I no longer have significant health anxiety and I'm not terrified of my body. And so to be able to feel confident enough in my body to donate part of my liver was kind of a huge achievement in terms of like my own recovery from OCD. And so I think that's interesting that you kind of called that out as one of the characteristics.
Oh, that's
Um,
really inspiring.
so let's circle back to kind of the beginning. Dr. Jackson, can you tell us a little bit about the burden of liver disease and the impact it has on people and what sorts of things people need transplants for?
Sure. So, in terms of the burden of liver disease, well, chronic liver disease is the ninth leading cause of death in the United States. Liver cancer, which is a common end stage result from cirrhosis, is the fifth leading cause of cancer related deaths in the United States. So, these are this is a huge disease burden in our country. The most common reasons to need a liver transplant for adults would be liver cancer that's detected early enough, where a liver transplant can be curative still. And the reasons to develop cirrhosis, the most common ones in our country are alcohol related and non alcohol related metabolic liver disease that used to be called fatty liver. There's also a variety of other reasons that people need transplantation. So, particularly women have an increased burden of autoimmune related hepatitis and cirrhosis. And there are also genetic disorders. And the most common reason that a child needs a transplant is because of biliary atresia, which is a condition where the bile ducts do not develop normally.
So all sorts of reasons. When you have non-directed donors, do people ever come in saying, I want to give to someone with this disorder, but not this disorder, and trying to direct where their liver goes?
I haven't had that experience except for with children and adults.
Okay.
That's the only place that I've had that experience personally so far. But I have enough communication with other centers to know that that has occasionally happened. I think we have to be very careful when we talk
Mhm.
about directing organs to different specific types of people, perhaps on the wait list. We have to be very careful that we're not, in any way increasing a disparity that might already exist. In general, we don't allow the donor to even really have much say in where that organ is allocated. The reason that donors can have that more influence in children versus adults is because in order to donate to a child, you're doing a smaller liver resection, and that's associated with lower risk in general. And so it's absolutely the donor's right to come forward for a lower risk surgery, which in the process of a natural the natural implication of that is for it to go to a child who's probably in more need. And so those complement each other very well.
That makes sense. Do you know the number of people or percent of people who have done living donation and then more specifically non-directed donation in the United States?
Well, in the United States, living donor liver transplantation accounts for about 5% of all liver transplantation. And so it's still really the minority. In some ways, that's remarkable to me when you think about, wow, this is an amazing life saving procedure. You can make such an incredible difference in someone's life. Over time, it's gotten safer and safer as we build more and more of an experience. Also, if you just look at the experience in Asia, the Western world has a very different experience than the Eastern world. So in the West, we started to do deceased donor liver transplants. That was very accepted here. And so living donor liver transplant almost became this secondary option. In the East, there were different religious beliefs or cultural beliefs where there was natural shying away from doing deceased donor transplants. And living donation really became the primary way to do liver transplants. And so that just in Asia in general, there's a huge living donor liver transplant experience with a lot of success. you'd think it would have all kind of come over to the US and been much more accepted than it is currently. It's certainly accepted. It's just I'm not sure why that volume still hasn't caught up to our outcomes. And then you asked how many non-directed donors there are nationally. I don't know the exact number. I believe that in about 2021, there were just over 100. And so I'm not sure how that's taken off nationally since then. The largest centers that have an experience with non-directed donation are the University of Toronto, UPMC, which is Pittsburgh, University of Southern California, Alberta, and us. And perhaps San Antonio might be catching up there also. So there's definitely a handful of programs that are doing non-directed donors. And specifically at our center, we've done 37, which, might not sound like a huge number, but when you think about the number of lives that that's saving, it's amazing. Some of those non-directeds are also now starting chains. So just like you hear about in kidney transplantation, where, like one one person starts this domino effect, that can start to happen in liver transplantation also. So we've started to do that in paired exchanges here. And, one person can potentially save 2 people's lives now or 3 people's lives. It's really amazing.
So that 37, how many years was that over?
We did our first non-directed donor in 2017 when Dr. Pomfret came here to the University of Colorado.
Okay. And speaking of that, can you tell us a little bit just in general about the history of our program here?
Yeah. Oh, goodness. I love being able to work at the University of Colorado. I came here from the East Coast specifically because this center has an amazing history of liver transplantation, and I wanted to be a part of that. So Dr. Startzel did the first liver transplantation here at the University of Colorado. He ended up leaving after a little while to go to the University of Pittsburgh and develop transplantation there and do his research on immunosuppression that really made liver transplantation possible. And about a decade or so later, I want to say, he had trained Dr. Yigal Kam, who he sent here to the University of Colorado from Pittsburgh. He's originally from Israel. And so he was the second chief of transplantation here. And Dr. Kam was here 2016 when he handed over the reins to Dr. Elizabeth Pomfret. She was the most experienced living donor surgeon in America at the time. She had been at the Leahy Clinic, and she came over here to be our third chief of transplantation. I mean, I don't think there are many centers that have only had 3 chiefs of transplantation. It is just really remarkable to me. Living donor liver transplant was first done in children. The first one took place in Chicago with Dr. Broch, who actually Dr. Pomfret trained with. And the first adult-to-adult living donor liver transplant took place here. And I believe that was actually, I forget the year, I'm sorry, but it was with the same surgical team that we have now. So just an amazing history here, an amazing surgical history, and amazing place to train and to grow.
Well, and I can say, like you said, Brandy, from my personal experience, it is an amazing team. It most definitely is. So for people who are hearing this and are perhaps maybe interested in considering donation, so 2 questions. One, Brandy, would you encourage other people to donate, or what are your thoughts about that? How would you talk to someone who might be interested?
I would definitely encourage them to donate. I would make it very clear that there are good things about donation and then there are complications that come up. So I'd be very honest about that. I didn't have any complications, but they do occur. I've heard a lot of donors on Facebook groups that are upset that they never heard from their recipient. And like Dr. Jackson said, it's very important when you get into this, especially if you're non-directed, to understand that there is a very good chance you may never hear from your recipient. And that's not a negative. It's not because they're not appreciative. I can't imagine being a recipient and having to thank someone for saving your life. I'm very lucky, and I know I'm very lucky that I have a relationship with both of my recipients, but that isn't always the case. So I would absolutely say consider donation, but you have to be aware that if you're donating non-directed, you just need to understand that you may not ultimately have a relationship with that recipient.
So what did the evaluation process look like for you?
It's all kind of a blur, but it was about a 2-day process. The main thing I remember was having, and this is where I met Dr. Jackson, a biopsy of my liver. And I don't believe that's with everyone, but I did need one. And I do remember meeting Dr. Jackson that day. That was probably, I think I was even more nervous for that than I was just the thought that you're awake, but it was non-eventful. It wasn't even as big as I thought it was, but it was a little bit more intense than the kidney testing. I did have to do a stress test on the treadmill, and that was an experience. So it is a little bit more in depth. They do go a little bit more in depth, especially I think if you're a kidney donor, they want to make sure that ultimately you are not going to have any issues in the long run.
Sure. And Dr. Jackson, from a medical provider's perspective, what are you looking for with the evaluation? What does that process look like?
Yeah. Well, anybody that's interested first fills out an online questionnaire at that uchealthlivingdonor.org. And it just starts out by asking you questions about your medical history. Things that would cause people to be ruled out immediately would be, major health comorbidities where we just thought that, it's not safe to take you to a surgery that you don't medically need. The other thing is remember that the liver is at risk of fat accumulation in it. And so we use body mass index as a general way to kind of risk stratify prior to people coming in. Then what'll happen is our donor coordinator gives the potential donor a phone call, just kind of checking up on things, making sure that this is something that really is a good idea for them at this point in time in their life and confirms their medical history. They get initial laboratory work done. Some of the things we're looking for are normal liver tests. So you want to make sure that your liver is normal if you're going to donate, And so we're even doing some extra testing for blood clotting. A surgery puts people at risk of blood clots in and of itself. We want to make sure that people don't have genetic risks for blood clots that would place them too high risk to continue that. And then, if all those labs are looking good, the person comes in for exactly a 2-day evaluation. This is something that we're taking very seriously. We want to be thorough and we want to keep the risks of a medically unnecessary surgery as low as possible. And I always just tell people we're going to be honest with you as we go through this. Some of this lab work that we do is lab work that we do in people who actually have liver disease, and we're trying to figure out why they have liver disease. But in a donor where we think that your liver is normal right now, we're actually just trying to see, is there a risk of you developing liver disease in the future where, we just shouldn't be taking a piece of your liver from you if you're at high risk of something happening in the future. The other thing we're doing is cardiovascular risk assessment, just to undergo a major abdominal surgery, and a CAT scan and an MRI where the bile ducts and blood vessels of the liver are sent to be 3D reconstructed so that the surgeons can see where is it actually safe to divide that liver. Could you be a right lobe, a left lobe, or a left lateral segment candidate, depending on the anatomy of the liver. Some of the other things that we're focusing on are ensuring that there's no fat in the liver, like we talked about. And some things that vary between centers are age. So at our center, we want donors to be at least 18 years old. And we're hoping that donors are about 55 or younger. We just know that as people get older, it's a harder surgery to recover from. Every center is a little bit different in terms of that age range. Body mass index is something that might vary from center to center. Role of the liver biopsy, just like Brandy alluded to. And we ask patients to abstain from alcohol for 12 months after donation. The thought process is that even though most of the liver regeneration takes place in the first 3 months, we really want to give your liver the best chance possible to regenerate and be healthy. And so we ask for that.
Brandy, is there anything that I haven't asked you that you would like to share with people?
No, I just think it's really important. Like, this podcast is super important to get the message out there. I think it's important to talk about organ donation because there's a lot of unknown. If you're not in the organ donation or living donor community, you simply don't know about it. I've come across people who aren't even aware that you could donate a kidney or what your kidneys do or what your liver does. I think it's very important to continue talking about it, which is why I love being asked to participate in things like this. I just think it's important to get the word out there and let people know that it is an option. And it does save lives, and it's very important to just keep talking about it.
Well, I'm very grateful for you for sharing your experience today, and same to you, Dr. Jackson. Thank you both. It has been a pleasure to talk with both of you.
Thank you. Thanks for having us.